Hi Raju, how are you today?
Good, Michael. Uh, Today we have chosen a paper that is of great relevance in the management of Kawasaki disease. I am sure you have heard of the two Janes in the US, Jane Newberger on the East Coast and Jane Burns in San Diego. Jane Burns actually is a confirmed Indophile. She visited India and my institution twice, and she is the lead author of this paper.
I can see that this paper looks at the management of IVIG resistance in Kawasaki disease with infliximab. This is very relevant since it would challenge the AHA and Japan guidelines, which recommend second dose of IVIG in case of resistance, which is seen in approximately 10 to 20% of the cases. So this could have a significant cost implication, especially in resource-challenged countries.
Besides that, Michael, let's not forget that IVIG is derived from pooled human donor plasma, and supply is always a challenge.
Correct. And there are a lot of routes practitioner could follow when children with Kawasaki disease have fever over 38 degrees at least 36 hours after the end of the first IVIG infusion. Incidentally, this is a definition the authors use for IVIG resistance.
True, three routes which are traditionally used: IVIG repeat, steroids, or infliximab.
But what about anakinra, an
Yes,
IL-1 inhibitor?
yes, IL-1 inhibition, very true. But first off, we know, and we have spoken about this in a few other podcasts, the availability of an IL-1 in many countries. But anakinra is considered one rung below, that is a third line kind of therapy. Meantime, let me just tell you that as far as the American Heart Association is concerned, it has assigned evidence level B to the second dose of IVIG or steroids, as is the case for non randomized studies, and evidence level C for infliximab as for expert consensus. But there has been another strategy that has been to select drugs that could be added to the initial IVIG regime to prevent recrudescences. So there was this study in Japan called the RAISE study. Now this used a scoring system, and in this scoring system, patients who were deemed to be high risk, they received prednisolone and IVIG right at the initial stage. But this scoring has a poor predictive value when populations are of mixed ethnic origin. Possibly the paper we are looking at today may change some concepts and practices.
The study design was a randomized open label crossover design, with patients failing one arm switched to the other treatment. And it was a large study with 30 hospitals in the US who participated and contributed to a total of 105 patients between 4 weeks and 17 years. And the primary outcome measure was resolution of fever at 24 hours after initiation of study treatment, with no recurrence of fever attributed to Kawasaki disease within 7 days post discharge. And the secondary outcome measures include the duration of fever from enrollment, duration of hospitalization after randomization, and changes in markers of inflammation and coronary artery Z scores.
This is very important to note, Michael, that clinicians or, on a day-to-day practice when we treat patients with KD, We need guidance for two different clinical situations. What is the best practice for patients at risk for aneurysms because of elevated Z scores on the initial echo? And the second, what is the best practice for patients with a normal initial echo but persistent fever after the first IVIG? This study, which they call the Kid Care study, addresses only the second part. This trial was not designed to address the prevention of coronary artery aneurysms. And there are reasons which the authors have cited why this was not possible in this study design.
Considering the US IRB, it must have been a nightmare to get clearances.
I think the authors were helped by three small studies in US, Korea, and Japan, but these were judged to have insufficient power. But it's likely that they helped the authors to build the hypothesis and present it to the IRBs.
Another difference I noted from these three studies you spoke about was that this study used 10 milligram per kilo of infliximab instead of 5 milligram per kilo. And the authors based this on the favorable safety profile and the pharmacokinetics of infliximab modeled from two randomized studies in patients with Kawasaki disease. Analysis had suggested that IgG from previous administration of IVIG might compete for recycling with infliximab. So a very important point is to see what is the interference with other treatments.
Now to the key findings, Michael. Ideally, I would strongly recommend that the listeners or readers please read the paper in detail, but briefly, 77% of the 52 patients in the infliximab group versus 51% of the 49 patients in the second IVIG infusion group met the primary outcome. 31 patients with fever beyond 24 hours crossed over. 9 in the infliximab group received second IVIG, and 22 in the second IVIG group received infliximab. The mean fever days from enrollment, the hospital stay, and such parameters also favored the infliximab group. All in all, the authors concluded that infliximab was a superior option to the second IVIG, and uniquely they found one adverse effect of significant difference between the IVIG group and the infliximab group, and that was that the infliximab group did not have any hemolytic anemias, while it was a significant adverse effect requiring blood transfusions in quite a few patients in the IVIG group.
So, Raju, this looks like a successful approach to IVIG resistance. But I must remind listeners that prevention of coronary aneurysm was not the end point. And I have seen also a few limitations which were cited in the discussion. There was no centralized evaluation of echocardiograms. And some centers applied treatment intensification for patients with high risk characteristics, inducing a potential bias toward patients with a lower risk of poor outcome. And in the study population, there was a disproportionate number of Hispanic patients due to the higher enrollment at the San Diego site. The absence of assessment beyond the first clinical visit allowed only short term evaluation of treatment effects, and we would like to know more on the long term. And finally, this is an open study with potential induced bias. Nevertheless, I think we can really use infliximab in the treatment of IVIG resistant Kawasaki disease. Any other final learnings before we close?
Yes, Michael, three learnings important for the practitioners. In Kawasaki, you cannot use ESR as a marker of inflammation after IVIG use. You would get falsely high values because it makes RBCs settle down faster. Secondly, in one dropped case in one of the arms, the eventual diagnosis was systemic GI. And this is always an important differential to consider when you are looking at such patients with suspected KD. And lastly, the meticulous description of the material and methods, right down to supplying uniform thermometers to all the parents. But knowing Jane Burns, I would expect nothing less.
As usual, very interesting. Thank you very much, Raju. See you next week.
Do you think today's discussion will help you in your practice the coming Monday morning?
Then join the G Academy forum by clicking the link below. We offer new discussion every week on different topics in pediatric rheumatology.